All right, how are you, everybody? So we have the Rescue ICP trial of decompressive craniectomy for traumatic intracranial hypertension. For the next slide. All right, so research questions. So decompressive craniectomy, or DC, is the removal of the skull and underlying dura. A little bit of background here. So there was a study called the DECRA study done in 2011 that demonstrated that there was no benefit from decompressive bifrontal craniectomy. However, the study was limited by restrictive eligibility criteria, and it did suggest that there may be a role for decompression in refractory cases. So the Rescue ICP study here kind of asks, what is the role of decompressive craniectomy for patients with a traumatic brain injury and intracranial hypertension refractory to typical medical management? Not not the initial approach. So you wouldn't have a patient that comes in and do a decompressive craniectomy right off the bat, treating refractory cases after medical management. So next slide. So the methods, a little bit about the design and oversight. So it's an international multi-center parallel group superiority randomized trial, with the sample size being 398, 202 undergoing surgery, and a control of 196. Inclusion criteria, ages 10 to 65. The patients had to have TBI with an abnormal CT. They had to have an ICP monitor already in place with ICP of greater than 25 for 1 to 12 hours. And an important thing to note here is that patients with surgery for hematoma evacuation were included in this study, as long as they hadn't had surgery like a decompressive craniectomy already. So this is something to note for the patients that were included here. Exclusion criteria, bilateral fixed dilated pupils, bleeding diathesis, or injury deemed unsurvivable, kind of sort of like the previous study. If you want to take a quick look to the chart over on the right, this just talks about the different tiers of treatment that the patients underwent before they were treated with decompressive craniectomy or given solely medical treatment. So stage 1, things that we already have covered in previous talks. If the pressure stayed higher than 25, of note, this for the tracheostomy, mannitol, saline, hypothermia. That's something else that's interesting to note. I believe that this study was done prior to results of the Eurotherm study, where hypothermia may or may not have suggested that there could be some deleterious effects in these types of patients. So I'm not so sure that hypothermia is used anymore. I think it's more normothermia, but let it be known that it was used in this case. If ICP is still high, then we move to either surgical treatment or medical treatment. So next slide. The outcomes. So the primary outcomes here were assessed with the Glasgow Outcome Scale at 6 months. Secondary outcomes included Glasgow Outcome Scale at 12 to 24 months. Also mortality at 6, 12, and 24 months respectively. Quality of life at 6, 12, and 24 months respectively. GCS at discharge, an assessment of ICP control, ICU time to discharge, and economic evaluation. There's a next slide. Cool. All right. And a little bit more about the methods. So there was a target sample of 400 with 80% power at a 5% significance level. So they allowed for 15% loss to follow-up. There was the outcomes were analyzed via an ordinal analysis method based on proportional odds model. And they performed a sensitivity analysis. So this is a pretty interesting point to make here. Conventionally, the Glasgow Outcome Scale in the literature is dichotomized with upper severe disability counting as being unfavorable. So if you look to the right at the chart, you can see upper severe disability. It's in a box. Traditionally, in the literature, that is declared as unfavorable, but those conducting this trial anticipated a high proportion of poor outcomes. So they included upper severe, which was an outcome score of 4, as a favorable outcome. So that's something to note here as well. So keep that in mind. Things like duration in ICU were measured with Kaplan-Meier estimates, and remaining categorical variables were measured with chi-squared, and continuous variables with Mann-Whitney analysis.
All right, so thank you, Michael. And now moving on to the results. So here's a few of the charts that were included from the paper. Table 1 talked about characteristics of the patients at baseline, for which there were no significant differences among the surgical group and the medical group, with the exception of the history of drug or alcohol abuse. There were 35% of participants in the medical group had a history of drug or alcohol abuse versus 24.8% in the surgical group. And then with regard to treatment and interventions, one of the significant things to note here is that for decompressive craniectomy, 37.2% of the medical group also received it, in addition to the surgical group, which may have affected the results, and that's something we'll mention later on. And then with regards to intracranial pressure control, that was one of the outcomes they measured. They found that patients in the surgical group had better ICP control compared to participants in the medical group. So with regards to primary and secondary outcomes, some of the main ones. So for primary outcomes, the GOSE at 6 months, we saw that for the surgical group, there were less percentage of patients experienced death, but there were more patients, even though there were more patients that survived, many of them were in vegetative state, had lower severe disability or upper severe disability. And that trend also applies for the GOSE results at 12 months. Patients, and we also see that there's a greater proportion of patients in the surgical group that ended up with upper severe disability, lower severe disability, and vegetative state than in the medical group. And so that's something we're going to be mentioning in our limitations as well. And we'll get to that in a couple slides. But some other secondary outcomes, as I mentioned on the last slide, ICP control was better in the surgical group. Time to discharge among the survivors was 15 days in the surgical group versus 28.8 in the medical group. And whether they did an intention to treat analysis versus a per protocol analysis, they found no difference in how they statistically analyzed their outcomes. So that's something to note as well. So with regards to the limitations, there's a few that that Michael and I found in this paper, and also the ones that they shared. So clinical teams caring for patients were aware of the trial group assignments. So there was some non-blinding involved in the study, and there may have been some difference in care, but the outcome adjudication itself was done by personnel who were blinded. There were a lot of patients in the medical group who got decompressive craniectomy, which I mentioned before is around 37%. So that could have diluted the observed treatment effect. They also did not dichotomize outcomes for bifrontal versus frontotemporal decompressive craniectomy. So it would have been interesting to see if there was a difference in outcomes between those two kinds of decompressive craniectomies. And 10 patients were excluded from analysis because of consent issues, and 7 in medical group were lost to follow-up. They also found no long-term data on cranial reconstruction, which happens usually 2 to 3 months after decompressive craniectomy. But they mentioned that it's an important aspect of treatment that should be explored further. They also didn't assess the effectiveness of primary decompressive craniectomy, which is done more frequently than secondary. And those are a couple of the sources that mention that primary decompressive craniectomy is more frequently done. And as we talked about before, for what's included as part of a favorable outcome, favorable outcome percentages for the surgical group might be artificially inflated because of what they considered a good outcome. So thinking about this last slide here, there were a larger proportion of patients in the surgical group with upper severe disability, which they considered a good outcome, which might have. So if we're just considering the green bars and the blue bars as favorable outcomes here at 12 months, there doesn't really seem to be much of a difference in favorable outcomes, whether you treat surgically or medically. And with regards to discussion, when we were talking about the DECRA trial earlier, craniectomy had worse ratings at USC at 6 months versus standard of care despite similar death rates. And early craniectomy is offered as a stage 2 treatment within 72 hours of injury for moderate intracranial hypertension. But this trial excluded intracranial hematoma patients, but these patients were included in this rescue ICP trial. That's something they wanted to make a note of to differentiate themselves from the DECRA trial. And overall, this trial, they were aiming to assess the effectiveness of DC as a last year treatment, as we talked about before. And it informs the concerns that craniectomy simply increases the number of patients who survive, but are in a vegetative state or in severe disability. However, they say the survival advantage was extended to dependent and independent living, which clinicians and families should know when they're making treatment decisions. And they were also not sure if ICP control accounted for a lower mortality specifically. They didn't test this association, but it'd be interesting to see if that association does exist. And so our references, and thank you for your time.
Thank you. This is Dr. Strupler again. So thank you so much for this very good summary. Why don't you go to your limitation slides? I think you had a good points there. So I want to unpack something you said. So I think the most important part is how they defined good outcome. Traditionally in trauma, we would put upper severe disability to a poor outcome when the GOSE gets dichotomized. This has traditionally been done. In this case, they put upper severe disability to good outcome. If you just would look up to upper good recovery, if you have craniectomy or not, there's no difference. But the difference comes in when you look at upper severe disability and put that in the good outcome category. So if you tell patients and say, so let me back off one more thing. So their primary outcome was at 6 months. We neurosurgeon, rarely follow our patients for longer than 6 months. We maybe follow them a year. Rehab physicians follow these patients. That's what they do for years. And if you go to a panel discussion or discuss this topic with rehab physician, they laugh you out of the room if you say to them, well, at 6 months, that's how we know how a patient is going to do. They say patients make significant improvement at 1 year and even out at 2 years. And this is an interesting point here because there is no significant difference at 6 months between surgery and not. But at 12 months, there is a significant difference to a better outcome if you do decompression, with the caveat that you put upper severe disability into the group of good outcome. Okay, so if that was published in the New England Journal of Medicine, which has a rule, you're only allowed to put your primary outcome in the abstract. So if people don't read the whole study, they read the abstract and they come away with another paper that shows that decompressive craniectomy doesn't work. Keeps people alive, but does not improve outcome. And I want to push back on that because at 12 months, which is the secondary outcome, they saw an improvement in good outcome with the caveat that upper severe disability is considered good outcome. The presenters of this paper pointed out that you need to discuss with the family what upper severe disability means. So what does upper severe disability mean for a patient? It means you can live independently at home for 8 hours. You probably cannot balance your checkbook, if anybody still has checkbooks. You probably cannot figure out the bus schedule, okay? But you can live independent at home for 8 hours. And I think that is a big part kind of my academical mission as well, is we need to learn how we talk to patients and to patients' families in this case, so they make the right decision. What's the right decision for the patient? Doing the surgery is very easy, but do we still have an understanding of what good recovery means in that case? So we talked about primary, secondary outcomes. Thank you for pointing out hypothermia versus normothermia. I think hypothermia is used as rescue therapy, and normothermia is almost should be standard of care in our severe TBI patients. I like what you put in there, bifrontal versus frontoparietal craniectomy. The reason is that bifrontal craniectomy, which they did in the Cooper trial, have much worse outcome, but it's more because it's more diffuse injury. And if you can do hemicraniectomies, there's mostly a lateralizing sign, and these people do a little bit better.
Hey everyone, Ryan Rad here from Neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.